Good morning, everybody, actually, or good morning, good afternoon, depending where you are. A very warm welcome to you on this second day of the antimicrobial resistance session. So welcome to those who were there yesterday and also for the newcomers. My name is Parveen Kumar, and I chair the British Medical Association's Board of Science. This is in fact a co-hosted meeting with the WMA, the World Medical Association, and the BMA, and this is of course the second session on AMR. The Board of Science has been interested in antimicrobial resistance for some years, and certainly some of our recommendations from a symposium we held some years ago was incorporated into the government's 5-year action plan on AMR. But there's still a lot more to be done, and indeed a lot more to be done on the international as well as the national level. Hence the reason for having AMR as our major theme for the science side of the World Medical Association. So today we were really going to focus on the pandemic, and the pandemic has really underscored the pressing need to preserve the efficacy of the drugs which we use to treat infectious diseases. And yesterday we had a very long discussion on various things, but one of the themes that were coming up was that we needed to be a bit broader and spread the news and with ramifications. We also need to get some data, and I think Dame Sally Davis was, and many of the other people say we really need data and need data now. It was also suggested that this should be a personal challenge that everybody should be taking on in terms of AMR, but particularly in terms of infections and preventing infectious diseases. So I think a lot of lessons came out of that, and we'll be, of course, sharing them with you later on. So today, again, we have a full agenda, many experts from around the world coming to speak on the subject, and they've all been doing work on the ground on these topics. So it'd be nice to hear from the ground. So just to inform those who are new, we have 2 keynote addresses, which we hope to have before the break for 15 minutes between the 2 sessions. So the 2 keynote addresses followed by questions and answers, then the break for 15 minutes, and then a panel discussion with further questions and answers. Just a little bit of housekeeping. Sorry to bore you with this, but the session will be recorded and the recording will be available later. The chat function, which I think all of us are used to, but can you please only use it for technical questions or if something has gone wrong and you can't get into the website, so not into the seminar. And the WMA will actually monitor the chat and help you out there. Please do not use the chat for questions to speakers, because what we want you to do is to raise the virtual hand and I'll call your name and then you can ask your question aloud. This gives us much more of an interactive feeling, which I think is important for a meeting like this. We're going to start off with the 2 keynotes, and I'd like to first of all introduce Professor Yune Arne from Rottingen, the Ambassador on Global Health from the Ministry of Foreign Affairs in Norway. Yune Arne, I hope I've got it correct. I do apologize, otherwise I'll call you John, I'm afraid. Is also an adjunct scientific director at the Norwegian Institute of Public Health and a visiting fellow of practice at Oxford University, Latvatnik School of Government. He was a founding interim chief executive officer of CEPI, a Coalition for Epidemic Preparedness Innovations. He's done a huge number of wonderful things. Chief executive of the Research Council of Norway, chief executive of infection control. I mean, it just goes on a bit, and he's also been an adjunct professor at the Department of Global Health and Population at Harvard T.H. Chan School of Public Health. So I think, I'm going to hand over to you, and I'm very much looking forward to your talk. Thank you.
Thank you very much, Parveen, and thanks for the opportunity to be here at this session at the World Medical Association. I'll try to share my Actually, it says that host disabled screen sharing, so that I think you need to activate my sharing opportunity from the technical side, I'm afraid.
Now you can do it.
Thank you. And just to confirm that you can see my first slide.
Yes.
Thank you very much. So again, thanks for the opportunity. And I've been asked to really place this in the context of our COVID-19 pandemic, what is now currently happening. And as we know, the pandemic is really a pandemic. It has crossed all the regions of the world. If you look at the number of cases and the number of deaths reported to the World Health Organization in this figure, for these two figures, you see that the first regions that were mostly hit when it comes to case numbers were Europe and North America. But then later on, South America in particular as well had a large number of cases. Number of deaths, a bit different picture, and the region with highest burden so far has been South America. But we also see that Asia and Africa have a lower both cases and deaths, of course normalized per population. But we can also assume that some of this is underreporting and the lack of capacity to diagnose COVID-19. So COVID-19 has had a devastating impact on the world. We have seen more than 230 million cases, more than 4.7 million deaths, and it had costed at least $9 trillion, $9,000 billion worldwide. The Access to COVID-19 accelerator was created as a mechanism to make sure that we could both develop and also make sure that we could have equitable access to vaccines, to tests, to therapeutics, to oxygen, to PPE, to all countries. And that has been the major undertaking as a partnership internationally. But in many ways, that partnership was not established beforehand. It was put together very quickly with its vaccine pillar COVAX in the early months in 2020, so March, April. So we have really built the bridge as we thrive in this pandemic. We now see on vaccines that we are increasing the delivery of vaccines in all regions of the world and across all the economic groups. And you see the distribution between high income, upper middle income, lower middle income, and low income countries. And you see the very small number of vaccines being delivered in low income countries in this figure. If you look at regions of the world, we now see that South America, North America, and Europe, and soon Asia, have been able to vaccinate 60% of their population. But in Africa, the vaccination rate is around 5%. And the full vaccination has only reached 4.2% of the population. So we also see that even with the successes of the vaccines, we also see the inequities in distribution of the tools we need. And this is even more clear in this map, demonstrating that in particular Africa, but also parts of Asia has very low vaccination coverage currently. And we really need to step up internationally to correct these inequity. Because we know that vaccines works. Of course, we know it from clinical trials, but we also know it from real-world evidence. And you see after the vaccines reached sufficient high numbers here in Portugal, Spain, and UK, there was really no and almost very low death rates in the same countries. But in countries with still low vaccination rates, you still see high number of deaths in the countries. So at least vaccines are very protective when it comes to reducing the severe disease, hospitalization, and deaths. So how do we see this in the context? Of course, COVID-19 being a crisis now, we have the economic recession that is definitely driven by the pandemic that we need to correct, and we have the bigger challenge of climate change coming. How can we position the challenge of antimicrobial resistance within this context? Because AMR, as you discussed yesterday is, of course, a global collective problem. It is a problem for all of the world, and we need to solve it collectively. We know that the more antibiotics we use, the faster they stop working. We know that a lot of antibiotics that are taken are unnecessary and prescribed by doctors or taken over the counter when it should not be used. And we also know that the problem is only getting worse and it's increasing. We have seen clear data on the relationship between the total consumption of antibiotics and the level of resistance in countries. A paper a couple of years ago documented this clearly for high-income countries, but what was also interesting is that there is not such a clear relationship in this data set when it comes to number of, or the amount of antibiotics consumed and the resistance level in low and middle income countries. And to me, that indicates that we have probably lack of data, that we have lack of a full understanding of the picture and the current consumption and also previous consumption levels. Because we know definitely that resistance is a big problem also in the lowest income economies. Here are data from Mali and from Tanzania. High level of colonization of ESBL bacteria in children, and very high level of mortality rates from gram-negative infections, definitely indicating antibiotic resistance as a major driver in Tanzania. But we should not forget that still in the developing world and in the world as in total, more people are dying from not receiving the antibiotics they need. And these are just numbers indicating the proportion of children receiving antibiotics when they have a serious pneumonia, community-acquired pneumonia. And in South Asia, Sub-Saharan Africa, the numbers are very low, and still we need to improve access to antimicrobials. Ensuring sustainable effectiveness of antibiotics is what I can call a bathtub problem. And if you see the sort of water level in the bathtub as a common pool resource. Because what we need is to ensure that we can have a sufficient level of this common resource, but then we need to ensure that we need to fill the bathtub with new antibiotics and at a higher pace than what we reduce the level of effective antibiotics due to resistance. And currently the water level is going down. So it is a collective problem. And I wanted to illustrate this and thinking of how we should handle this collective problem by looking into what the global system of health, the global health system with its 4 functions should do. Because in the literature, the global health system should provide 4 functions. The overarching function is to provide stewardship and leadership. Then we have, we have 3 different functions. It's the provision of global public goods, the functions we all need. It's about managing externalities, managing cross-border health threats like epidemics, pandemics, but also antimicrobial resistance. And it's about providing solidarity, capacity building, and assistance to those that need them at most. So how do we then use these 4 general functions and think about antimicrobials and antimicrobial resistance? One is that we need, as I said, universal access to antimicrobials and to prevention of infectious disease, and make sure that all health systems have the capacity to deliver this. Then we need innovation of new antimicrobials, and that is a continuous effort because we know that evolution of antimicrobial resistance is happening and it will happen over the years to come. So we need a continuous inflow of new antimicrobials. And then we need effective tools to make sure that we only use antimicrobials when needed. So we need a conservation strategy to ensure antimicrobial effectiveness. And to have an oversight of this, we need proper surveillance systems and accountability. So how can we then look at a policy framework for antimicrobial resistance, or what you can rather call a framework for sustainable access to effective antimicrobials? First, I think we need to start with universal access. We need to have that as a starting base. Without access, we cannot really treat infections. Then we need to make sure that that access is not excess. We need responsible use. We need to reduce demand of antimicrobials or the need, and also supply. To reduce the need, we need infection prevention. We need vaccination. We need infection and control programs to make sure that we can reduce the incidence of infections, thereby reducing the need for antimicrobials. And to really have an overview, we need surveillance and monitoring and understanding the problem. And to deliver on this, we of course need research and development and innovation. We need a solid knowledge base. And this is not only a human health issue, it's also an animal health issue. So we need a One Health lens and a One Health approach. In a series of papers in Lancet some years ago, we were discussing what do we need to do collaboratively across countries to make sure that we can deliver on these objectives. So we looked into surveillance policies and where we needed international collaboration. And the higher up in this pyramid, where we say at the top, we need collective actions, so we need common mechanisms, we need potentially collaborative decisions, or at least we need coordination. So the higher up, the more challenging international collaboration will be. So we need at least to improve national, regional lab capacity, and we need better international collection and analysis and sharing of surveillance data. On the infection control and access policy side, we identified ensuring global affordability of antimicrobials, making sure that drugs are accessible and affordable in all countries. We need donors and governments to prioritize access to effective antimicrobials in their policies. And we need financing for implementation of infection control interventions, to mention a couple. Then on responsible use policies, there are many, and where we do require stronger international collaboration. We could even think about a similar regime as we have for narcotics. But I have just said this in quotation marks. But some type of regime where we have better control internationally of the valuable drugs that antimicrobials are. We need to reduce the use of antibiotics in particular as growth promoters. We need common standards for marketing of antibiotics, and we need to restrict some specific classes to human use to make sure that the most valuable can be used in clinically necessary conditions. Then on innovation policies, we suggested that we need, of course, to finance and perform the necessary R&D and support new business model that can both reward innovation, but at the same time ensure responsible use and access. So some level of pull, we now know that push incentives, so the increased investments in R&D has really happened across the board. We have a better pipeline of antimicrobials today than before, but we need to pay for antibiotics in the market in a different way. We need stronger pull incentives to continue incentivizing, finalizing this chain of research and development. But at the same time, we need to ensure that those incentives are given in a way so that it can ensure responsible use. So that was thinking around antimicrobial resistance and sustaining the effectiveness of antibiotics and the policies we need. But then back to the pandemic. We are, of course, still in the pandemic phase. Sorry about this. And we need now gradually, and will gradually go into a transition phase. What we now need to hope for is that the pandemic will not be forgotten, because we see an increasing number of epidemics caused by zoonosis, as well as new influenza spillover events. So, so both are increasing. If you look at the trend from the 1960s in total spillovers, and if you look at influenza spillover events from the mid-90s. If you combine and look at the severity of epidemics in the period from 1960 until today, and if you do a log transformation, you see a very clear linear trend. And the trend is, of course, caused by urbanization, by deforestation, by climate change, by other environmental factors. And you see within the confidence boundary, the COVID-19 pandemic is still, but is of course an outlier. But overall, the picture is clear. We will see an increasing number of epidemics and pandemics in the decades to come. So what do we do then, policy-wise and internationally, to better collaborate on governing epidemics? There are already several post-COVID-19 reform proposals on the table. There is a proposition to establish a Global Health Threats Council or a Global Health Threats Board, which would have, or which will make sure that we have better accountability and surveillance and follow-up of both countries' activities to prevent and prepare, as well as the international agencies' role in doing so across the One Health agencies. We have the Global Health Threats Fund proposal, or the proposal to establish a financing facility. We had from the G7 presidency of the UK a proposal for a pandemic preparedness partnership that will really deliver countermeasures, vaccines, tests, and therapeutics for future epidemics. And then we have the pandemic radar, a much stronger and better surveillance and alert system. We have established the ACT Accelerator, as I mentioned, and there is a proposal now to use that experience to establish a sustained platform that can be also operating outside and before emergencies, so that it can work much more expeditiously when a crisis occurs. So in a way, an ACT A 2.0. Then there are proposals to strengthen the international health regulations, making sure that it's implemented and that all countries are in the position to actually do have the core capacities, as it's called in the international health regulations. And finally, there is proposals on the table for having a pandemic treaty, a framework convention on preventing, preparing for, and responding to epidemics in the future. So many policy options are currently being discussed, both in the context of UN, the WHO, and in the G7 and G20 fora. One group, the G20 High-Level Independent Panel on Financing the Global Commons for Pandemic Preparedness and Response, where I was a member, we came up with 4 key recommendations, and that is to fund a globally networked surveillance and research system to prevent and detect emerging infectious diseases, to support more resilient national health systems to strengthen the critical foundation for global pandemic preparedness and response, and then to fund both the development and supply of medical countermeasures and tools, and make sure that we can radically shorten the response time when a new pandemic occurs in the future, and that we can really deliver equitable access to these countermeasures in the time of a crisis. And finally, a global governance system to ensure with a finance and health board that can ensure the system is tightly coordinated, properly funded, and with clear accountability for all actors on outcomes. Because global health security is really a global public good, and that is both when it comes to pandemic preparedness as well as antimicrobial effectiveness. Those are both global public goods. So how do we ensure global public goods? Because global public goods can come in different types and forms. And here are 5 categories of global public goods, and I've provided some examples to illustrate one of them. Because some public goods are dependent on the total aggregate efforts of all countries. those could be efforts to reduce unnecessary use of antimicrobials in human and animal health sectors. It can be efforts on prevention, both within environment and food safety, to reduce zoonotic spillovers and to prevent infections in general. Then there are other types of public goods that depend on the weakest link, that the chain is not stronger than the weakest part of the chain. And that is really a good example is our capacity to detect emerging pathogens and infectious outbreaks through a properly robust surveillance and alert system, but also to detect and have better data, as Praveen said in the introduction, on the evolution of antimicrobial resistance and have data from all countries and all regions. Then there are some public goods that are dependent on better coordination, and those are examples like common norms, standards, and interoperative systems so that we can really enable the sharing of information and data across countries and make sure that we have a common picture of the total challenges. Then the fourth category of public goods is the so-called single best effort. Some efforts will depend on breakthroughs, for instance, that we have seen with the mRNA vaccines now in the context of COVID-19. Because we need then at least that a core group of countries and systems with capacity can develop and make sure that we have a warm-based capacity for production of medical countermeasures like vaccines, tests, therapeutics, and other technologies, both relevant for epidemics, but also relevant for endemic infections, and that those capacities are available in all regions of the world. Because I believe what we have seen in this pandemic is that we are very vulnerable to the fact that governments' first responsibility is to protect their own citizens, and that's why we have seen export challenges and thereby also import restrictions implicitly, or import limitations, I should rather say, when it comes to delivering vaccines. And then finally, we also need some joint regulations to prohibit and ban activity that can pose risks and can increase the threats of infectious agents. So what about then, what are the commonalities? Because I was asked to discuss what lessons can we learn now from COVID-19. Are there commonalities between pandemic preparedness and response and working on antimicrobial resistance? And I've stolen or used these points from a recent REACT briefing paper. Because of course we know that the zoonosis aspect and the need for a One Health approach is a commonality. We need a One Health perspective when solving AMR, as well as preparing for and preventing epidemics. We need better global surveillance for both viral and bacterial infections, as well as the evolution of antimicrobial resistance. We need a more health needs-driven research and development model, because we know that both in the context of antimicrobials and antibiotics in particular, but also for epidemic diseases, there is really not a viable commercial business model currently for developing developing new technologies, given the uncertainty in the markets. So we need a needs-driven model where public sector and philanthropic sectors play a more important role than in the normal business of R&D in medicine and health. And we need to increase the transparency and the strengthening of global pharmaceutical supply chains. And when I say global, I mean also with strong regional capacities in all regions. And then finally, a commonality that we need to ensure equitable, affordable, and timely access to health products and to prevention efforts. And of course, ensuring a stewardship function, making sure that we have access, but without excess and irresponsible use of the tools. So what about the differences then? I talked about between AMR and the Pandemic Preparedness and Response, PPR for short. One, I think we have seen an unprecedented resource mobilization for tackling the pandemic. I only use here what is raised of funding for the Access to COVID-19 Tools Accelerator in a year time. So we mobilized $18 billion new money to really deliver vaccines, therapeutics, diagnostics, and protective equipment to countries. That is still not enough. We need still $16.6 billion to close the gap for 2021, and we need additional funding to really control the pandemic in 2022. We have also seen unprecedented investments in R&D for COVID-19. These are some old figures from last year, but still it illustrates the magnitude. More than $9 billion invested in COVID-19 R&D in less than half a year, which really demonstrates the ability of the global society to mobilize when there is a common threat, and is something that we do align on. I was involved in establishing CEPI, the Coalition for Epidemic Preparedness Innovation, and I led it from the beginning. And we, of course, established that organization after the Ebola outbreak in West Africa. So one of the concrete outcomes from when it comes to improving our system was the establishment of CEPI. CEPI has now played an important role in coordinating and funding the development of vaccines for COVID-19, and is continuing playing that role. And it demonstrates that it is possible to have an impact and actually make change on the global scene when we have a common understanding of the threat and the need. So what about then funding for health-related AMR research and development? And these are numbers from also from last year, but it illustrates that over a 5-year period, we had a total of around $3 billion investment. So much smaller than the investments gone in only half a year for COVID-19. So we need to increase our collective investments in AMR, and we need to compensate for the fact, as I said, in particular when it comes to the development of antibiotics, that there is not a commercially viable market without changing the way we operate that market. We have now a much stronger system when it comes to funding early and research, preclinical and also early clinical development. That is through grants and to better coordinating the pipeline. We have initiatives like CARB-X, that is a common international initiative of Europe and the United States in particular. We have BARDA, we have the new AMR Action Fund from the industry, we have the GARD-P partnership established by the NDI and the World Health Organization, and we have initiatives out from the European Commission. But where we do still lack a common approach is on the market entry and incentive side. So that's the pool incentives and a way to reimburse and pay for antibiotics differently. So that's on the R&D for PPR and AMR. But then I wanted to illustrate the difference of actually the capacity to monitor and have a surveillance system. In a very short time, we have now, as you have seen in all media and in different systems, and I've just used one example here, is a dashboard of the Multilateral Leaders Task Force. So it's a collaboration between the WHO, the World Bank, IMF, and the World Trade Organization that has a dashboard of all countries, all individual countries' situation when it comes to COVID-19, as well as accessibility and availability of medical countermeasures like vaccines and therapeutics. This is just one example of the increased investments in actually data generation and oversight of the pandemic. We know that we also have an initiative on this when it comes to strengthening surveillance for antimicrobial resistance as well as antimicrobial consumption, the GLASS collaboration. But we know that still many countries are not covered and that the investment level of this system is far too low. Then finally, I wanted to discuss how we can collaborate better to achieve better sustainable effectiveness of antibiotics, because most countries are small. I've illustrated this by Norway, a population of 5 million, and that is more or less like the median country in the world. So most countries of the world are small countries, and we can only deliver on tackling antimicrobial resistance by collaborating, because there are many collective action problems. What we have when both it comes to prevention, when it comes to innovation, when it comes to conservation or responsible use, as well as access to antimicrobials, we have so-called collective action policy problems, because there are coordination challenges, for instance, harmonizing surveillance data. There are challenges related to free riding, so free rider problem, because if some are increasing public investments in R&D for antibiotics, all will of course benefit. So we need a better system for making sure that everyone contributes. We have unrealized positive externalities. Of course, if we can control infections, if we can make sure to reduce the infectious disease burden, that will be a positive for everyone. But those positive externalities are not taken into account when countries make decisions. We have global commons dilemma, because the making sure that we have sustainable effectiveness of the pool of antibiotics is really a common pool resource. And then we also have negative externalities if we increase the access to antibiotics and antimicrobials without ensuring good stewardship and conservation strategies. So how do we handle those collective action problems? Yes, we need, unfortunately, to meet in big forums, like here, an example from the WHO Executive Board. We need to negotiate and agree among countries. And this is a commonality now, both when agreeing to post-COVID-19 reforms in the pandemic preparedness and response system, as well as for agreeing to improving the system when it comes to antimicrobial resistance. And I've used then what is emerging as potential solutions out of COVID-19 and see how that could also link to the improving the global governance for antimicrobial resistance. Because, as I mentioned, there is now an effort both to strengthen international health regulations, but also to create a framework convention on handling pandemics, and I think both of those could integrate measures to better handle issues around antimicrobial resistance. Because, of course, antimicrobial resistance is also a health threat, and we need, as I've illustrated, there are a lot of commonalities of what we need to ensure that we can control it. There is a set of proposals for developing in a more sustainable way tools and solutions for pandemic preparedness and response. And those initiatives could also integrate the thinking on how we make sure that we have a sustainable way to develop new tools for, in general, for treating infectious disease and controlling and preventing infectious disease. Then there is a new financing mechanism being discussed both in the context of the G20 as well as in other contexts. And that financing facility is not a new implementing body, but it's a mechanism to add additional funding to this already established system in global health. And that financing facility could also take on the responsibility to mobilize resources, both for ensuring access, but as well as ensuring responsible use of antimicrobials. And finally, there are discussions on establishing stronger oversight and accountability at the political level through a Global Health Threats Council or a board, which could also have an oversight function on antimicrobial resistance. But just to repeat this, we need to have an overarching One Health approach, because both access, infection prevention and control, conservation or responsible use strategies, and innovation, we need to take both a human health and animal health, an agricultural health or a food system approach, as well as environmental health approach. when finding solutions, because they need to work in all these 4 sectors. So what I propose is that we need to use the opportunity now in the context of the discussions post-COVID-19 to create a global framework that could integrate the needs both of PPR and AMR. It could include a set of core national responsibilities or obligations, a set of core collective global responsibilities that we need to invest in and do together. Then we need financing mechanisms. And finally, we need oversight and compliance mechanisms to make sure that what can be seen as an UN-based normative framework can integrate with what I would believe would need to be an open and a broad coalition-based framework that could include substantial financing and investments. So with those words, I would like to thank again for the opportunity to address you and looking forward to the panel discussion. Thank you.
Unani, that was an amazing talk, full of really full of a lot of both challenges and solutions as well. I think you sort of pointed out how it really is so important to have overall collaboration across the globe and tackle these things one by one. And I think the other thing that made me sort of realize is, you know, countries are small. You really need to get them all together. And yet you've got to reach them all. So a lot of problems there. And I think, again, you emphasize, you know, that it's about getting research and data together. And the, you know, rather interested also in your pandemic preparedness response and adding the two together. That seems to me, you know, two things that could actually work very well together. So thank you for that. And I think what we'll do is go on to the next talk, if we may, and then come back to questions with you. That'd be terrific. Thank you very much. I see Dr. Ramanan is here. Welcome, welcome to this meeting, Ramanan. What I would do is just say a few words about you, and then perhaps you could tell us all about yourself as well. So you're the founder and director of the Center for Disease Dynamics, Economics and Policy in Washington. And your main job at the moment is director of the Center for Diseases there at the moment. You also work between Washington and New Delhi. You seem to be everywhere, as far as I can see. I've seen your TED talk just to get a flavor of you, which was lovely. You chair the board of GARDP, a global product development partnership, which is developed by, I think, the WHO, and also aims to provide sort of new treatments and for bacterial infections. And you do a whole host of things, including helping the Obama administration in this field, which I see is enormous. So, Ramanan, welcome. And we'd be delighted to hear your talk. So over to you. Thank you.
Thank you so much. Thank you for having me, Dr. Kumar. So, you know, it's a pleasure to be here. And unfortunately, I only caught the tail end of Jan Arne's talk, but I'm sure he gave you the full global overview on the problem as I expected he would, and also in terms of mechanisms that are in place or are not in place really to deal with AMR. I wanted to sort of dive into a little bit more of the, how shall I put it, just in terms of sort of under the hood in terms of where things are with respect to on the ground policy, you know, movement on AMR, and especially in the context of COVID. So I hope you can see my slides.
Yes, we can see it.
Yeah, great. Fantastic. So what we have to remember is that secondary bacterial infections in the context of pandemics are all too common. So even in 1918, in the flu pandemic, the secondary bacterial infections were a major cause of influenza-associated pneumonia and death in both civilian and in military personnel. So this has been done with a whole number of tissue studies that, you know, sort of go back and looked at folks who died, and many of them were positive for Staph aureus. Now, of course, that was an era where Staph aureus was not treatable at all in 1918, and now we're back in a state where many situations where we have Staphylococcus aureus are not treatable with the drugs that happen to be available, you know, in the front line, and certainly with MRSA, having been around for at least for the last 25 years now, being community associated, we have a real challenge here. So I sort of call this going from 0 to 0. We had no drugs then, and now we have no drugs that work every single time reliably. So we've gone through a golden era of antibiotics, and we've landed back, unfortunately, close to where we started. Now, if you look at time to illness, from illness to death for influenza-related pneumonia deaths and pneumococcal pneumonia deaths, in that period of time, it was very similar. And also if you look at the proportion of deaths, so roughly peaks at exactly the same time, a number of days. So it was hard to distinguish, except that now the molecular methods that we have allow us to do these kinds of studies. We saw this also during COVID, which is that there's been a lot of COVID co-infections and superinfections in patients who have COVID-19. So this has been shown in this European study where many of the patients who were admitted had also other microbiologically confirmed infections, and mostly due to Pseudomonas and to E. coli. We see this also in terms of cross-country studies in terms of secondary infections in COVID-19 patients. Wherever it's measured, obviously a significant proportion dying, and certainly the evidence seems to be that one is worse off if one has a bacterial superinfection, regardless of which country the person is in. And this was a study that was published in India, which is a little more detailed than some of the others, which looked at resistance profiles in clinical isolates causing secondary infections in COVID-19 patients. And you can see that, you see for, across the range of antibiotics, the proportion resistant was pretty high, quite significant, in fact. And if you look at, again, that same study, a different study, again done in the same country, which is India, what we see was that 3.6% of the patients developed secondary bacterial infections, fungal infections in COVID-19 patients, and gram-negative bacteria were isolated from 78% of patients. And you see Klebsiella, Acinetobacter, and those are the most predominant bugs, but you see pretty much everything, and particularly fungal pathogens, which I'll get back to in a second. So here we are with challenges with your Nana laid out quite well, and which in a sense we have not made progress on, because it's almost like the world came to a stop in 2 years. Market failure continues to discourage the development of new antibiotics. We have made progress since 2016 in a number of ways. We now have the AMR R&D hub in Berlin. We have better research happening through the Joint Programming Initiative on AMR. We have CARB-X and GARD-P, which are taking care of early stage and late stage antibiotics. But we still don't have enough antibiotics, or anywhere close to what the pipeline used to be about 25 or 30 years ago. The second thing is that, and surprisingly so, infection control remains weak despite COVID. There's no real evidence that in many low and middle income countries that COVID has really caused hospitals to really upgrade their infection control in significant ways that would then play a role, afterwards. I'm not saying it hasn't happened. I'm just saying that it hasn't been well documented. There's no evidence that this is really happening. Now, looking forward, we've got a bigger challenge now, which is now that we sort of are done with the brunt of COVID thanks to the vaccines, we now face climate change. And climate change, I think, is going to be a huge challenge both to AMR, but also to drug-resistant fungal pathogens, which are becoming increasingly, finding a hospitable environment in humans, and drug resistance because of the use of azoles, both as fungicides as well as for drugs, is likely to make it difficult to treat these pathogens. Now, these next few slides come from the State of the World's Antibiotics report, which we put out at the beginning of the year. We do it every 3 years or so, just to sort of document where we are every 3 years with respect to antibiotics and their effectiveness. And what you see here is that if you look at defined daily doses per capita, and the left side is high-income countries and the right side is low and middle-income countries, antibiotic use is still pretty high, and down is resistance, which is also pretty high regardless of, it's higher in low and middle income countries, it's lower in high income countries, but we do have a challenge in both places, and with high levels of consumption. we compute something called a drug resistance index. I apologize, it's been cut off at the top. But the drug resistance index is basically like a stock market index, which is like a weighted average of resistance, weighted by how frequently that antibiotic is used. The light blue is high income countries, and the dark blue is low and middle income countries. And what you see is that for most countries, you still have high levels of drug resistance, which means on average, it is difficult to treat bacterial infections in these countries in a reliable manner. We see overall increases in total antibiotic use that's been growing over time since the year 2000. China actually, declined for a little bit and then started growing again. But if you look at French West Africa or Francophone West Africa, I apologize, in Brazil and Saudi Arabia, it's all growing. If you look at consumption, particularly of access and watch antibiotics, then you see that that has actually been increasing over time in low and middle income countries, but decreasing in some places. So these are access and these are watch. So there's actually a decline in the access antibiotics simply because resistance has made these antibiotics relatively useless. So a lot of people have switched over to the watch antibiotics, which is not what they should be using. All of you may be familiar with the three categories of access, watch, and reserve antibiotics. And the watch antibiotics are ones that are meant to be on formulary and not used very much. But turns out that they are the ones that are being used most widely across most of the planet. When we look at antibiotic resistance in animals, in chickens, pigs, and cattle. And why do we care about animals? Because we need to treat animals as well. And resistance in animals is a problem, for the well-being of the animal industry. That has also been going up significantly. It has doubled since 2000 to 2018, and the trend lines all continue to go up for chickens and pigs, not statistically significant in the case of cattle. And meanwhile, the antibiotic development pipeline between 2013 and 2019, this is what it looked like in 2013, which is we had a bunch of drugs in phase 1 and phase 2, not so much reaching the end. That has certainly improved. We now have some drugs which are hitting the other end of the pipeline in terms of approval, but we have all too many examples of companies like Achaogen, which had an FDA-approved antibiotic, but still was not able to make enough money to be able to justify continued investment from its investors, and then had to go belly up. And we see this happening all the time. There have not really been examples of companies that are able to innovate and then survive in the antibiotic space, and this continues to be a major concern. Meanwhile, on climate change, now I'm looking forward because I feel we need to really look forward in terms of where we are going to be with bacterial infections. We now have consistent evidence that gram-negative bloodstream infections are associated with higher temperature. So in fact, we find that for every additional percentage, this is the additional percentage in bloodstream infection per 5.6 degrees centigrade increase in monthly temperature. This is pretty significant. It's about a 10% increase in bloodstream infection frequency for Acinetobacter, 3.5 for E. coli, 8% for Klebsiella pneumonia. Now, I'm not saying we're going to see a 5.6% increase in monthly temperature on average, but certainly some months you're going to see these increases, and you're going to see increases in secondary, in gram-negative bacterial pathogens. This has now been documented across a number of studies. This was a meta-analysis that was done by McFadden and others in Nature Climate Change. And you can see quite significantly that the trend lines are going more sharply upwards in terms of the response of resistance to minimum temperatures. And this is going to be a cause for concern. We don't understand these phenomena well enough yet, but let's just say that climate change is going to make bacterial infections, and particularly gram-negative infections and resistance, more common and not less common. And climate change may also be driving greater adaptability to higher temperatures amongst fungal pathogens, which frankly is what is near the top of my worry list at this point in time. We've seen these kinds of studies where climate change basically makes it possible for fungal pathogens that reproduce at avian and mammalian basal temperatures, which means that they're able to survive in warmer and warmer climates. The reason they don't do so well in us is because we're much warmer than the ambient environment. But when the ambient temperatures are going up and the fungal pathogens are being selected to survive in those higher temperatures, it means they are, as a consequence, being selected to survive in us as well. And it's an easy hop and a jump for them to also gain thermotolerance, salinity tolerance, jump to birds, and then come to places where humans and birds are in constant contact, and then jump finally to humans. And we're now seeing this with Candida auris, and I suspect that we will see a lot more of fungal pathogens in the coming years because of this greater adaptability. Now, that's all the bad news. Now, the good news is that there are some opportunities, and I see some positive trends coming out of COVID-19. The first is that I think globally there's a better understanding of zoonoses and One Health. Now, it still doesn't mean that One Health is practiced in the way that it was conceived or that there is strong linkages, but at least there is now a movement towards setting up the kinds of partnerships, relationships, joint funding that would make it possible for us to address all future pandemics, which include those which are driven by drug-resistant pathogens. And on that, I'm certainly more hopeful at this point in time. The second is there is a recognition of the value of science and of scientific enterprise, including of development of drugs and vaccines, because of the success that these have brought to the fight against COVID-19. And I think this recognition will translate into money, or has already translated into some money, and will for AMR as well. Hopefully, all the stuff that Janana put up in terms of the money that we need for AMR will actually fructify as a consequence of that. Now, the third and the fourth are the ones that I'm going to talk about in a little more detail. The third is a big deal, I think, which is that there's now greater acceptability of adult vaccines, which is a key tool against AMR. We've always sort of wondered, well, what is going to be the main tool that we use against AMR? We've talked of water and sanitation, infection control, better stewardship, etc. But reducing the need for antibiotics, particularly by using vaccines, has always been a significant part of that puzzle, but never really quantified. Over the last 3 years, CDEP, working with the Gates Foundation, the Wellcome Trust, and the World Health Organization, has published a series of papers which really look at the effect of vaccines on AMR. I'm not going to talk about all those papers because that would be a 2-hour talk in itself. But I'm just going to talk about a few of these just to say that the evidence is very promising in terms of the data. Where vaccines have been deployed, there is good evidence that antimicrobial consumption does go down, and in some cases, resistance also goes down. And lastly, we'll talk a little bit about innovations in surveillance, which have happened in the context of COVID that could be translated to AMR as well. So if you look at pathways in which vaccination against focal bacteria and non-focal bacteria and viruses, and I say viruses because I'll explain to you in a second why that's important for controlling antibiotic resistance, the actual figure looks something like this. It's if you look at viral pathogens that you have greater vaccination, less susceptibility, fewer susceptible to the non-focal pathogen, and then fewer cases of non-focal disease, which means less antibiotic use at different levels: care, health, pathogen, population, and the direct level. But if you really break that down into a very simple picture, this is what it means. It means that vaccines lead to fewer infections, which means there's less disease burden and less transmission, lives are saved. You also have less antibiotic use, reduced selection pressure, and therefore you reduce drug resistance, and therefore lives are saved that well. And all antibiotics, all vaccines will have an effect on one manner or the other. In some cases, it's because a viral pathogen is being inappropriately dealt with using antibiotics. And so oddly enough, one of the best things that we could do is a seasonal flu vaccine or a universal flu vaccine could be one of the best things we can do to reduce antibiotic consumption and therefore reduce selection pressure and save lives, even though antibiotics are not indicated for influenza. Now, some of the best evidence we've had comes out of the introduction of the pneumococcal conjugate vaccine. This is just one of multiple studies that were done in the 2000s looking at penicillin-resistant and penicillin-susceptible disease, which showed that the introduction of PCV7, the pneumococcal conjugate vaccine in 2000, resulted in decrease in both of these. It also resulted in a decrease in hospital visits. Now, influenza in the United States is actually nearly perfectly predicted by antibiotic sales data. Now, this may shock you as it should, because it just means that much of antibiotic sales is being driven inappropriately by influenza and seasonal influenza. In fact, these dotted dashed lines and the solid line almost sit on top of each other. And that's worrying because it means that a lot of the antibiotic use is really inappropriate. We know that. You found Yeah, we find both a decrease. We find that when vaccination is introduced, that you find lower incidence of antibiotic consumption, and the total vaccine preventable antibiotic consumption and incidence is estimated here and is quite significant, whether for rotavirus or for pneumococcal infections. We've done the same thing for tuberculosis as well, and a future TB vaccine, which will hopefully come soon, could avert 10% of resistant TB cases and about 7% of deaths over 2020 to 2035, with significant impact in the countries which have the most TB. So these are the prospects for post-exposure tuberculosis vaccine, which are like an M72-like vaccine efficacy profile, and it looks quite promising in terms of what it can actually do, regardless of which country. So these are all obviously codes for countries, but I'd point you to the main paper, which was published earlier this year. And this is the country-wise contribution to vaccine avertable deaths from for rifampicin-resistant tuberculosis in various countries. India, of course, has the most TB and therefore has the largest contribution there. Now, last point is that first of all, we've done those studies in many other pathogens, so I can share the full set of papers there, but it's quite exciting. I think vaccines are going to be, hopefully, a major approach to dealing with AMR, and I think we should follow on what CEPI is doing and really try to focus what CEPI is doing also on the need to tackle AMR as one of the ways in which to deal with the problem. The last point is really to do with surveillance. Now, again, this is a long topic. We've developed a lot on diagnostic tools, on surveillance methods, but this is just one example of it, which is that we've always had evidence, at least for some time, that you can measure bacterial resistance from sewage samples, and you can actually correlate it with urine and blood samples from the same hospital. This was one study that was published based on data from 2016 in Sweden and is now being replicated in other countries as well. Sewage surveillance is really now taken off as a way of detecting COVID-19 as well. In fact, there's now some evidence that finding COVID in sewage is, helps predict when the wave is going to take off in a particular city. And I think these innovations from COVID and the extra attention that COVID surveillance has received could and should be translated into what we can do for AMR as well. So I realize I'm short on time, so I'll stop here and just say that the things to keep in mind here are that, oh, I'm sorry, I forgot this one, this was on typhoid, that we again have good estimates for fluoroquinolone non-susceptibility and multi-drug resistance by country in the case of an introduction of a typhoid vaccine, and this has just actually been accepted. And what we see is that the introduction of the typhoid conjugate vaccine would, including a catch-up campaign to age 16, could avert 826,000 deaths and 44.4 million DALYs due to typhoid fever over 10 years following introduction. So, this is just all by way of saying that, yes, there's bad news ahead as well because of climate and our failure to tackle AMR in a serious way. But there are some positives that grow out of COVID as well, and hopefully we can build on those in conversations in years to come. All the data that I presented are at resistancemap.org or on the website, and I'm happy to take questions during the panel. Thank you.
Sorry, just having. Thank you very much. I'm not quite sure whether it was frightening or something that I should be pleased about. But it was lovely seeing the challenges, and I think the opportunities that sort of that you suggested have really, made me feel that really we can be there. I mean, one of the problems, of course, is why, with the antibiotics, the drug companies can take it so far and then can't afford to keep it going, which is a great shame, really. So, Roman, thank you very much indeed. Just to tell everybody now, we are on to the question and answer for both the talks that you've heard. And as we did yesterday, I'd be grateful if you raise a virtual hand, which will then come up on there, so it'll be able to tell me where we're going to go. So are the speakers happy to get questions live from people? Okay, lovely. I see Mary McCarthy from the UK has got a hand up. Mary, would you like to ask your question?
Thank you, Parveen. It's more a comment, really. In Europe, with the One Health project, the EU JAMRI AMR research body, which has just closed, commented that during COVID, in fact, antibiotic prescribing fell, both in animal studies and in human studies, and that infections also fell. And anecdotally, as a GP in the UK, I certainly saw no child with bronchiolitis last winter. And in our local hospitals, the rate of C. diff infection has dropped like a stone. And I just wondered, is it the hygiene measures and the social distancing that were imposed during the COVID pandemic that has resulted in less infections and therefore less antibiotic prescribing?
I can take that. Actually, there are studies which are in conflict with each other with respect to that finding. In some parts of the world, you actually see greater antibiotic prescribing because people inappropriately treated COVID-like symptoms with antibiotics. But certainly in more developed countries, there was a drop overall in infections, especially respiratory infections that were non-COVID, potentially because of social distancing. Now, we have to also remember that while that likely did not happen in the UK, the lockdowns or other measures did restrict access of people to doctors during that period of time. So it may have appeared as if fewer people were showing up, but that was just because they couldn't really access a doctor because they couldn't, many clinics were shut, many outpatient clinics were shut. So it's hard to disentangle what actually happened. But I suspect that because it was more difficult to access antibiotics in some places because of lockdowns, that consumption did actually go down last year. Although I have to tell you, there are studies showing both increases and decreases during 2020 that have been published so far.
Just to add on from my perspective, and I think the picture is mixed, as Ramanan is saying, but indeed in many countries, I think we also have seen a very clear impact on the in general sort of social distancing and infection prevention measures on incidence of infections. So what does that tell us? I think one, we may sort of be able to maintain some of that preventative efforts, and I think we have definitely educated our populations. But at the same time, of course, in particular the social distancing and the hard lockdowns have had negative effects that we're not looking for. So the question is, how can we maintain some level of increased hygiene efforts in the general population, but without having the negative impacts, of course, on the general lockdown efforts. And I think we saw the same actually in Norway also during the swine flu pandemic, where we saw, because of increased hygienic measures in nurseries, kindergartens, we saw a reduced incidence of respiratory viral infections in hospitals for that season. Now, of course, we are concerned about whether we will have an upsurge of RS virus infections in hospitals, I guess, in many countries. So we'll see whether this levels out in the total time frame.
Thank you very much for that. I also expected that antibiotic prescribing would go up but was surprised that even in my own practice, it actually dropped. And I put that down to increased hygiene measures. And maybe that is something we can learn from COVID. Thank you.
Massive one thing that everybody knew about was hand washing, and you know, I think that's been a savior really from our point of view. Unfortunately, in certain countries you can't have that, because I remember going down a hospital, going along a corridor trying to wash my hands, and there's a row of taps, but of course you turn them all on and there's no water coming out, so you know, need other measures as well as hand washing. So I see Dr. Jamaluddin from Bangladesh. You were very noisy yesterday. I'm delighted to see you back here. Would you like to ask your question, and perhaps we could see you as well?
Oh, thank you so much. Actually, my first question is to Dr. Narayan. You were just showing us that there is a study in India. There's 3.6% of COVID-19 patients developed secondary infections. But here in Bangladesh, we have seen almost all the patients got admitted. They were given the antibiotic, namely meropenem. So this was empirical. Actually, they just went for the investigation. Rather, they haven't gone for it, and they have straightway given that. So this way, actually, I think it's correct that AMR. Don't you think that as a top organization, the WHO could have given a much more this definitive this informations that this sort of practice should be stopped rather, and so I think in COVID-19 era actually AMR probably it has gone more high, I can say, and more antibiotic uses were there. It's right. So what do you think about this? Number one. And number two question is to the Professor Dr. Rottington. That is actually you are talking about you're in CEPI, and you have shown some 5 or 6 measures which you have mentioned about the treaty, about the pandemic treaty. You see, almost 1 year we are past, almost nearly 1 year we are passing. The vaccine has been started given, and some countries have already vaccinated more than 85%, and some countries are only below 5%, 10% like that. So some countries, they have got the ability to produce the vaccines, but they have not got this information, or rather you can say they haven't got the substances to produce the vaccines. Whether you think that this sort of the producer actually or the inventor during the pandemic, it should not be their right just to keep it within themselves, because they do not have the enough capacity to produce and to vaccinate the people. Even some countries could not arrange the vaccine. Even they wanted to buy it, they didn't get the vaccines. So what is your opinion about these things? Whether the treaty you are expecting to go for it, it should be included there that during the pandemic, this sort of practice should not be there.
Okay, Jamal, thank you very much indeed. Yonani, perhaps you ought to go first, because you've just heard the rather long discussion. Do you want to go first?
Yeah, no, happy to discuss that. And Shamal, you are definitely right that we have a situation today which where we have very stark inequities in access. And of course, the main reason for that is that the overall supply of vaccines in the world and the capacity to produce have not been in line with the needs. Then there are also very strong efforts now in building up more of that capacity by technology transfer. Definitely, there have been good examples of that, of course, to India in particular, but then India really needed all of its production capacity for its own needs. So now there are efforts to transfer technology to, in particular, the continents and the regions that have very little capacity today, including Africa, which really has no or very limited vaccine production capacity. But then the issue is what you are alluding to is really the issues around the intellectual property and also the ongoing discussions in the World Trade Organization on whether to issue a waiver, a TRIPS waiver on COVID-19 related technologies, so that any producer can start producing vaccines and other technologies without being sort of sued by the original IP holder. I think these discussions will continue. There's still not a consensus at the World Trade Organization on this. But my thinking is that indeed a future system would need to take these issues into account, and the norms around technology transfer and making sure that we have sufficient capacity in all regions will need to be a part of a convention or a treaty for pandemic preparedness and response. The big issue is, of course, whether we can agree that in a UN body like the World Health Organization, or whether we would need other fora as well. My thinking is that we need a combination of general principles and norms that are related to ensuring access in all regions and across all income levels. But then in addition, we need public-private partnerships where we, based on the funding that the public is providing, we will also have some clear conditions and conditionalities when it comes to ensuring access. And CEPI is one organization that has used those conditions. But as you know, the CEPI has only been able to invest in some of the vaccines, and other vaccines have been not taking money or at very limited funding from the public sector, and are therefore not under those conditions, and have delayed, or at least not decided on technology transfer in an active way. So it's a complex debate.
Thank you. Roman, would you like to answer us?
No, I was going to say, I think Dr. Jamaluddin was basically agreeing with what I had said, which is that the secondary bacterial infections are a problem where infection control is poor. And I think his question about why there was not more guidance on dealing with them, and particularly with fungal pathogens, we had a lot of what was called black fungus in India, is appropriate. We should have anticipated this, knowing that viral pandemics do result in secondary bacterial infections, and we just didn't get ahead of this in the way that we should have. Thank you.
Okay, thank you. Thank you very much, Dr. Uddin. Ottmar Kloiber was one of our experts yesterday. He's the WMA Secretary General. Ottmar, can we see you?
No, I don't think so, but I hope you can hear me.
We can hear you, certainly.
That's
nice to have you back. Thank you.
Thank you. Thank you very much. And for the ease, allow me just to use your first names. That makes it much easier for me to pronounce it correctly. Thank you, first of all, for very excellent talks and really great talks, showing the problems, but also giving some perspectives. But let me put some questions on the perspectives if you allow me to do so. You have deeper insight into what governments currently do and what they are discussing. And we are looking forward to having a stronger discussion about the international health regulations and the pandemic treaty, where I think many people put a lot of hope in. Just this morning, I had a discussion with my colleagues from the other health professional groups, nurses, pharmacists, dentists, physiotherapists. And we were wondering what was going on with this discussion about the pandemic treaty, because here in Geneva, we are hearing nothing from WHO about it. There is no inclusion of civil society whatsoever. There is really zero communication on this. We don't even know whether it is planned to have a pandemic treaty this fall, or whether this will be a first talk about a pandemic treaty. So could you enlighten us a little bit what is going on, and what really are the plans, and are there material one can read, what will be included, how this would look like? And the second question to you is, in hindsight, with the experience of the international health relations, with the experience of some other treaties, like for instance, the Tobacco Framework Convention Control, with the fact that we are in a world which is experiencing very strong political polarization right now, and we have seen a nationalism during the COVID-19 pandemic, or a national egoism during COVID-19, which has beaten everything we have seen before. So what makes you really hopeful that this will work and really will make a difference. This is my question to you. And if I may, I have a second question to Ramanan.
Should we do that? Can we do that first? Because this is
okay, fine. Yeah, certainly.
Ramanan can have a little breather. Yonani, I'm sorry, you're on again.
Oh, thank you, and thanks, Otmar, for excellent questions. So first, I should say that I had hoped that the World Health Organization actually have included civil society as well as non-governmental organizations, including the professional organizations, more into the as a part of the discussion now, and I can make sure to at least give a signal back to the World Health Organization Secretariat on the need to fully brief you and your organizations on this. As you know, probably earlier this week there was I guess the third meeting of the working group that was established by the World Health Assembly, and the working group is, at least now my reading, it's of course a negotiation between countries, often complex now in the virtual space, but they are moving forward with thinking that we probably would need to do both. So it's not an either or approach to either strengthening the international health regulations or having a new convention or a treaty, but it's actually a both approach, and that hopefully that will be discussed in the special session of the World Health Assembly in November, late November. And there at least the organizations will be invited, I know, because that would be more the normal nature of the governance of the World Health Organization. Your second question on vaccine nationalism, I think my approach to that is that, as I said also in my talk, there is, or just now in my previous answer, I guess, countries are, and country governments are mainly, their first and primary responsibility is towards their own population. And when you have a very supply constrained market when it comes to important tools, I think it's almost impossible, even in a perfect world, when you have no world government, I think it's really impossible to challenge the fact that governments will first prioritize their own population. I think they need to do some more from an enlightened self-interest, understanding that the pandemic needs to be controlled most efficiently by actually allowing all countries to first vaccinate their most severe, or the patients or the individuals with most risk, but that is a broader debate. But my thinking then is, how can this affect the negotiation climate in many ways? I believe that at least we have seen that in a crisis when we are not prepared, we will go to the first principles and actually looking for our own population. And we have seen that that is not the best total response. So I hope that when it comes to preparing for and actually preventing epidemics, the country leaders now have seen that the only way to work together would be to be better prepared and set systems in place and investments on the table to avoid such a situation. And I think we need to differentiate between the sort of vaccine nationalism or the national response perspectives, and also the understanding that better preparedness collectively and together can actually go hand in hand. And the latter could avoid the former if we prepare properly.
Ramanan?
Oh, I don't think he'd asked me a question yet.
Yeah, I have not yet asked the question.
Oh, right, okay, can you ask the question first?
Yes, of course. I'm happy to do so.
Yeah, thank you.
And thank you for Yonana. I hope that the world shares your wisdom and also your insights there. Let's see that this really comes to a better situation than what we had before. Yes, and to Ramana, my question is on the One Health sphere. Right now, what we see a very high consumption of antibiotics in food and animal production, animal and food production, in husbandry. And a lot of that is not for really health reasons, it's more for economic reasons. In some countries, it's still for growth promoting, as you know. In many countries, it's just to allow mass breeding in a way of farming, which I refer to as dirty farming, which is really prone to health problems with the animals, but it's also prone to health problems with the human population by an excessive meat consumption that we certainly have and which we have to correct. So I'm not yet sharing your optimism that politics has seen that things have to change there. Just recently, the European Union, what I understand, is opened either more a floodgate to use last reserves antibiotics for the food production and the animal production there, instead of reducing this effectively and strictly. Perhaps you might want to comment on this as well. And the second one is, I share your sentiment, or actually your insight, that vaccination is one of the major tools actually to help us in coping with the AMR crisis we have. But we are living in a world where politicians tend to stress the belief that being against vaccination is a matter of personal freedom. Is that a political luxury we can afford in this situation, really? Thank you.
So both really good questions, and worthy of debate, because there's no conclusive answer here. On the latter one, my slightly more narrow point here is that prior to COVID, across most of the world, the concept of adult vaccinations just really doesn't exist. It exists in the developed world for seasonal influenza, but you take most middle-income countries or low-income countries, there really isn't adult vaccination. Introducing both the concept as well as the delivery mechanism for adult vaccination then opens the doors for getting people to accept vaccines which would be useful against AMR. So it is in that sort of perspective that I thought this could be helpful. But certainly there's lots of issues to do with vaccine hesitancy, with lack of sort of cohesion around vaccines, all being issues at this point in time. Can you hear me? Sorry.
Yeah.
Now, on the first part, on One Health, I think there is progress being made. Oddly enough, it isn't being made in terms of reducing meat consumption, which I think should be taken up seriously. Although China is now trying to do it with its citizens to try to encourage people to cap the amount of meat they eat every day, much like you'd want to cap, how much someone drives, for instance, to not being excessive. But certainly the optimism on the vaccines could potentially translate into animals as well. If we make huge improvements in vaccine technology, we could probably have animal vaccines that could reduce the need for antibiotics. In fact, the reason why antibiotics are used for growth promotion in animals is really as a substitute for animal health, for nutrition, for there being a veterinarian and hygiene. And if we can improve on those fronts, it actually doesn't make sense to use antibiotics in animals at all. But there is certainly a lot of work that lies ahead here. And again, my narrow point here is that prior to COVID, people didn't even realize that diseases emerge in animals and spread to humans. At least now we have politicians who recognize that happens. And that then opens the door for us to then say, listen, this is happening for COVID. The same situation could happen for resistant bacterial pathogens, say for MCR1, which emerged in pigs and then spread to humans. This sort of thing is happening for drug resistance all the time, and therefore we should take up One Health as being, a serious endeavor at the global level beyond just viral pathogens. We should think of it with respect to AMR as well.
Thank you very much.
Thank you. Thank you very much. Oh gosh, I'm sorry. I've just looked at the time. I think time is up. But can I just thank both the speakers? I mean, it's just been a superb morning, and please don't go away, because you're coming back with the other experts we have in the afternoon. So everybody, thank you for listening in. We've got 15 minutes, and I think Michael's going to put up a clock so that we know when to come back. So please have a lovely drink and come back reinvigorated. Thank you very much.
Thank you.
Well, welcome back, everybody. I hope you've had a nice coffee break or tea break, depending on where you are. So we're now into our panel session, and I welcome back Ramanan and also Yunane, who hopefully will appear in the middle. We also have 3 new panelists, all experts in their fields, and really it's wonderful that we've managed to get so many experts all together. So the 3 are Professor Sabia Esak, who I think is speaking from Cairo. Sabia is South African Research Chair in Antibiotic Resistance and One Health, and also Professor in Pharmaceutical Sciences at the University of KwaZulu-Natal. She's also been Vice Chair of the WHO Strategic and Technical Advisory Group for Antimicrobial Resistance. And she's got many other titles, but I won't talk to you about them. Next, we have Merfin Mpundu, who, there he comes. Hi, Merfin, nice to see you again. And Merfin is Director of REACT Africa and is a member of REACT Global Leadership Team. He also has 20 years experience in the field, including pharmaceutical supply chain management, infectious disease, antimicrobial resistance, global health security, global One Health, international health, etc. So welcome, Merfin.
Thank you.
And lastly, we have Heidi, who was previously speaking to us from a car. Heidi Tensmaren is the president-elect of the World Medical Association, and congratulations, Heidi. We look forward to your reign soon. And she previously chaired the WMA Medical Ethics Committee from 2017 and 19. But she's also been president of the Swedish Medical Association and also chair of the Swedish Medical Journal. And I think, Heidi, I think you're an anesthetist and an intensive care specialist at the back of all this. So, ladies and gentlemen, what I suggest we do is I'm going to ask each of the 3 of the new speakers to say up to 10 words or anything they want to say about themselves or what they're doing, all around the context of antimicrobial resistance and anything they can add. So if we start off then, Sabia, should we start off with you, as that's the first one on the list?
Sure. So thank you very much. Yes. Can you hear me?
I can indeed. Thank you.
Thank you very much. It's always a tough act to follow when it's Ramanan and Yon Ans, but I'll try my best. And maybe I should, since you asked me to speak about what I'm doing in the broader context of AMR and COVID-19, I should say a little bit about what I'm doing in my research program in my small part of the world in the district in KwaZulu-Natal. So my research program addresses surveillance and alert systems, the weakest link that Yonan mentioned in a single district in KwaZulu-Natal in South Africa. So we discussed earlier that COVID-19 has changed the antimicrobial selection pressure by altering antimicrobial use as well as biocide use. And this could have been either escalation of use and therefore escalation of resistance, or de-escalation, as we saw the experience in the UK. So, and I speak specifically in terms of low and middle income countries, the impact of COVID-19 on AMR is unquantified, because in a number of countries, AMR surveillance was deprioritized in the pandemic response. And so it's a bit early, I think, to observe AMR changes through existing surveillance systems. So what we're working on in South Africa is ALARMS, an acronym that stands for an alternative antimicrobial resistance monitoring system, and we're trying to show proof of concept. So what we're doing here is we're undertaking metagenomic analysis of the microbiome of vulnerable human and food animal populations and the associated environments. And in one way, closing the sewage clinical isolate loop or clinical AMR loop by including the sources of the sewage. So what are we seeing in sewage, what the actual AMR profile is in populations and human populations and animal populations. And we believe that this will give us a more accurate picture, as we will also be able to characterize resistance in viable, but not culturable bacteria, because we're taking a culture-independent approach. And we hope to show that environmental monitoring is a good proxy of emerging or escalating AMR. So it sort of expands on the Global Sewage Project and takes a metagenomic and a culture independent approach. So Professor Kumar, that's my day job. I'm also working on access to critical antimicrobials and diagnostics in low and middle income countries by way of an antimicrobial subscription and pooled procurement project. And we've just had the paper on this accepted in the Lancet Global Health. And it's not just a paper, but we've taken, I think, quite a few steps to make this a reality. So we heard earlier that about delinking and push and pull models and incentives related to antimicrobial research and development. But we also know that most of these efforts to stimulate the pipeline and ensure access have so far been in the more developed or higher income countries. And this means that we are not really addressing more than 80% of the global need, which is for people who have infections in resistant infections in low middle income countries. So our ASPP or ASP project is sort of expands on the Netflix type model, but takes a market shaping approach through multi-year subscription contracts for portfolio of antimicrobials and diagnostics that is negotiated for by a consortium of participating countries. So it's envisaged as a hybrid in which some countries will self-pay and others will receive aid. For example, low-income countries would receive support from the Global Fund or UNITAID, as is the case now. Middle-income countries would self-finance in a similar way as to how vaccines are paid for by PAHO and its revolving fund, where member states pool their national resources to procure vaccines. And then this sort of consortium of countries would be anchored by market leaders. So the obvious choice in Africa would be South Africa, and we would be the anchor and invite other countries to be part of this consortium. And we hope that this portfolio approach sends a clear signal to manufacturers that products will be procured when quality, safety, efficacy, and pricing criteria are met. We've interacted with our National Department of Health, the South African Development Bank, as well as the BRICS Development Bank. And I'm cautiously optimistic in terms of us translating this into something tangible. We want to ensure that stewardship is included in this model, and we've deliberately included diagnostics. It somehow resonates with the WHO's Secure initiative, and we have interacted with them also. And I think what makes the case in this in what we're doing is that we've taken two case studies from South Africa and India that illustrate the exponential increases in both AMR and antimicrobial use to the watch and reserve antibiotics over a 5 to 10 year period, which really shows the need for new existing as well as new antibiotics to be made available to low and middle income countries. But we're not just focusing on the new and the newer ones that come in, because we also have huge issues with unavailability of existing drugs and getting manufacturers to start manufacturing them such that countries can have access to those as well. So I'm going to stop there and let others have a chance to speak as well. Thank you.
You're on mute, Parveen.
Yeah, sorry, I've also, that must be the word of the century, wasn't it, for this last year? You're muted. Unmuted slightly better than muted. Thank you. No, Sabia, I was just saying you're absolutely right. Sort of talking with these wonderful experts around is slightly worrying, isn't it? But you are just as much an expert as everybody else. So Merfin, over to you. Thank you.
Thank you so much. Like Sabia, I'm in Cairo, and it's hard to follow very good presentations excellent presentations from Ramanan and Rottingen. But just probably a bit of myself and what I'm doing. As introduced, I'm the director for REACT Africa, and I'm also the partnership and engagement lead for the International Center for Antimicrobial Resistance Solutions, ICARS. A honorary research fellow at the University of KwaZulu-Natal, and the co-chair for the external advisory board of the Newton AMR drug discovery program. So one of the things that I've focused on in the last few years has been to actually support the African countries develop and implement their national action plans. And one of the major challenges that we have seen is that there's been quite a great loss of momentum from what we had seen between 2015 and about the middle of 2017, when countries were developing these national action plans. And the sort of actually the drive for implementation has been a huge challenge for most of the countries. And some of the work that we have focused on has been to try and support these countries that are struggling in the region in terms of prioritization of the interventions that they have put in their national action plans, to be able to actually promote and support, build capacity and pilot a number of programs. We are piloting stewardship programs in 3 countries, and these are countries that are quite challenged. I think one of the things that we'll discuss a little further, I think, in this discussion is that, when we're talking about actually AMR, and we're talking about some interventions around access and conservation, some of the practical challenges that are there when one looks at actually stewardship is that, some basic building blocks of stewardships are not just in place. And in a practical sense, it's very challenging. Just 2 weeks ago, or last week, actually ending into last week, I was in one of the countries in West Africa, and they really, lab capacity, isn't there. They can't do any cultures, they can't do any ASDs, and so most of these countries, even just the presence of guidelines, a huge challenge, and that is actually where we come in, and we try to focus on supporting some of these countries get the basic actually infrastructure and the basic knowledge that would help them in addressing antimicrobial resistance. We are certainly very active at the communal level, at the granular level, in terms of activities around raising awareness on AMR and ABR. We are very active at the national level in terms of supporting countries develop and also, translate national policies around AMR beyond the National Action Plan. For example, looking at AMS, actually national policies, and also very active in the region in supporting the regional economic blocks to develop strategies that support their member countries in implementing AMR strategic plans. The other area that I've been very active on has been in the area of bringing the voice of the Global South into the global agenda, because a number of times when the global events or global decisions are made, there's very little consideration of the voice of the Global South. And so, folks like myself and the organizations that I'm working with, we try to bring that sort of actually voice and the sort of needs that are left out, whether one is looking at research and development, whether one is looking at the issues around access, which have been brought out. That voice is not actually heard coming out. The other area is that we've been actually supporting with ICAS in terms of looking at the low and middle income countries with implementation or research as an approach to implement national action plans. And so, that is one area that we have worked on. And then, of course, as Rotngan had mentioned earlier on, we've worked in the area of trying to stimulate and debate in terms of research and development. And we've been quite we've issued policy papers. We've been able to actually advise on the issues around, really, how do we address really sustainable access to effective antibiotics? We've talked about really establishing global coordination entity for early stage R&D, establishing a global system of target product profiles to align our research efforts with the global needs, increasing public financing, and the issues around that most of the prescribing that occurs in most of the countries that we work on, it's driven by what is available, and it's and not necessarily what the patient actually needs. And so those issues, and in the COVID times also, we had seen that the sort of actually misinformation and the sort of dichotomy between access and excess was very evident. And when there was, for example, the touting of actually azithromycin as a treatment, we saw long queues of actually patients, or not patients at drugstores trying to buy azithromycin because it was being actually flouted. And so the issues around regulations and all those areas are issues that we try to work on. So with that, I think I'll pause and then wait and get into actually further details in terms of the particular emphasis and areas of this meeting. Thank you.
Thank you very much, Martin. That's very kind of you. Heidi, would you like to?
Unmute myself. Hello, everyone. Nice to see you all. It's been very interesting, and I'm going to say a little bit about what WMA does and physician around the globe does in this topic. And what I can say, what the physicians are doing is what you are doing, since you've all been addressing the work of the physicians. But in the aspect of COVID-19 and what we have learned, so secondary bacterial infections have, well, our knowledge about that and our work with it go way back, and also our engagement in this, of course. And this is one of the reasons why the WMA promote vaccine campaigns so much, so that vaccine can be accessible and available for everyone globally, and how we collaborate through different global institutions to see to that we have a high vaccination rate in the population. And not only, of course, the vaccines towards COVID-19, but all vaccines. We have for many years addressed the market failure, as Ramanan pointed, as a problem, and we have worked actively with that. And there have been several discussions where we have been involved, not least on the European level through the CPME, but also on the national and global level. And despite many good intentions and incentives, we are not really there yet, but maybe in the future after listening to you. The WMA has, through the European organization, addressed the need for a finance model for this to fund research for new antibiotics. I'm going to say a little bit about our work, but I just want to highlight what actually Ramanan pointed out about the environmental change and the impact on global antimicrobial resistance and the effects. Because I guess many of you have seen David Attenborough's film about a lifetime on the Earth and the loss of the biodiversity. And what we know when the COVID-19 vaccines were so rapidly put forward, a key knowledge in this and doing this was about the biodiversity and the knowledge from biology, and a lack of biodiversity will of course be very bad for research and putting forward new techniques and vaccines. So that's why WMA also engage in promoting to have, well, to slow down their environmental development. We also have policy making. So WMA is to a great extent policy and advocacy, and we promote the data sharing of data, and with the protection of the integrity of the individual. So this is a balance here. And what we have seen during the pandemic, that there has been pushing of the limits for the integrity for the individual, but there have also been gains by sharing data. That's what we promote. And as Junana also pointed out, the sharing of data and developing new digital techniques to track data and get aggregated data has been crucial. And for me as an anesthesiologist, I forgot to say that, well, anesthesiologists, I worked in the ICU during the first wave, and the sharing of data where we can share between colleagues in Australia, in America, or South Africa and Sweden was crucial in developing new treatment techniques. So just before I go on to the WMA policy, I'd like to tell you I used to chair the Swedish Medical Association. I used to be president there and also chair the Swedish Medical Journal. But my background in anesthesiology and intensive care was from big surgery, transplantation, and organ donation. That's why I also later chaired a national board of organ donation in Sweden. And I've been on the committee for Sweden's government's Life Science Advisory Board and Research Sweden, and so on. So that's a little bit my background. And in the light of transplantation, organ transplantation, we all know that antibiotics are crucial. If that fail, we probably won't be doing many organ transplantations. So. The WMA started way back working with the AMR issue, actually. We raised the issue very early in the early 90s, and we have been working with other international organizations on the issue, like the International Society of Antimicrobial Resistance, School of Public Health and Policy, and not at least the World Veterinary Association. And we have a couple of policies on the topic, like the WMA resolution and collaboration between human and veterinary medicine. Because as you have all addressed, I take out some of the issues I want to point because you pointed it out. But of course, the prescriptions in human medicine is one thing, but the veterinary medicine, also food production, is a huge problem. And we, at the moment, have discussion on collaborating on the joint education of physicians and veterinarians on prescriptions of antibiotics, and also to encourage the assessment of the antibiotic treatments and the prevention of spread. And in our policy, we also very much address the healthcare, the access to healthcare, and the equity, because the primary prevention of infections and the spread of infections are important. So this goes from poor living conditions up to research of new antibiotics. And what we also stress is, of course, the global collaboration. The global collaboration is probably one of the most important things we can do today in the light of the pandemic, to see that we support the global institutions, give them mandate to form policy and guidelines, and also funding, of course, of vaccines, because as Murphy pointed out, you prescribe what you have accessible, and therefore we need to collaborate about this and have common guidelines. And I just addressed two more things. In our policy about AMR, we also stressed the greater use of vaccinations to reduce the burden of infectious diseases. I've mentioned that in the beginning, but that's really what we can do. It is already there. It's many times not the issue about new technology. It's about infrastructure and funding to get it out to the population, and so we can do that. That's possible. And last, the WMA stresses the role of experts on higher decision levels. We can act as physicians toward our individual patients, but the expert knowledge is very much needed on higher decision-making levels and in the global institutions. So I think that would be my last words. Greater support and mandate to the global institutions, and collaboration in governance and funding. Thank you.
Thank you very much, Heidi. That was three really very interesting perspectives from different angles. So that was excellent. So ladies and gentlemen, it's now your opportunity to be able to ask our expert questions. Again, can I remind you, if you kindly raise your hand, the virtual hand, it'll come up there. I'll be able to see it and call you in, and somebody will then let you in, and then you can speak yourself. So please do that, and don't feel frightened of doing that. So panel, while we're waiting, we've got some questions that will be sent, and maybe we can just start by looking at them before people come in. And the first one really is how, and partly we've sort of answered them partly, but it'd be quite nice to get it all together. How can innovation for AMR in the research and development arena be fostered? Any thoughts on innovative mechanisms of financing or priority setting? Who'd like to start that off? Okay, Ramanan, thank you.
Sure, no, I'm happy to do that. So this is a really important question, because usually this question gets then targeted at new antibiotics. And I think new antibiotics are only one part of the solution, and probably not even the biggest part. I think the big innovations will have to come, as I mentioned earlier, on vaccines. They will have to come on infection control, which is scalable in resource-poor settings. Just as you mentioned, Parveen, to not have taps with running water, but to be able to do infection control in those settings, how we might do that is really a challenge. It comes with water and sanitation, and figuring out how we can get chlorination and things that we take for granted in developed countries also available in developing countries as ways of preventing infections. That's one set of innovations. We need another set of innovations on diagnostics. We talk about it a lot, but we really don't have the ability to quickly detect or differentiate between viral and bacterial pathogens at a price point and accuracy that would then actually influence care. So this is another area for technology to really work. And I think, last but not least, there's a lot of work to be done on innovation, on nudges, behavioral sort of nudges, things like physician feedback, things of that nature, to be able to just cut down on antibiotic prescribing. Now, this is all just in the human domain. We should remember that there's a lot of innovation required in the animal and environmental domains as well. Very similar sorts of innovations, vaccines, hygiene, nutrition, all of these apply to those domains as well. And we have to figure out how to not use antibiotics on fruit trees. We have to, figure out how to get goldfish raised without being fed antibiotics. We don't realize that, goldfish actually consume a lot of antibiotics. I just don't mean just goldfish. What I mean is that the places where antibiotics go are so obscure and so pervasive that we really need to think about alternatives to them in multiple spaces, because right now their use as an industrial input far exceeds their use as human medicine, and we need to change that.
Roman, you made two very good points. I mean, yesterday we discussed the diagnostics, and it was quite interesting because, I was asking about point of care, is there anything we can get quickly? Is this a virus or a bacteria? Do we give antibiotics? Do we not? And one of the answers was, yes, they are there. They're quite expensive. Nobody's buying them. But the major thing was behavioral. If you can't get them to accept that this could be done change your ways, change your thinking, change the software in your brain, and think differently, you can get away without antibiotics. Jon Arne, thank you.
First, I would like to say I agree with Ramanan. We need to have a very broad approach to what kind of research and what kind of technologies that are needed to address infectious disease. And I think that we definitely should go outside antibiotics. Having said that, I think we also need continued emphasis on new ways of treating infections. There is a renewed interest in phage therapy, still very challenging, but definitely something that I think you should be looked more into. And I also I was intrigued by the subscription model that Sabia described. So in a way, a combined approach to diagnostics and antibiotics, and making sure that we can also incentivize private sector to contribute sustainably to this, not by a sort of pay-per-pill model, but actually by paying for a more continuous service of available both diagnostics and drugs. I think we need to also be innovative actually on the reimbursement side of the coin. Yeah.
Thank you. Mervyn?
Yes, I just wanted to actually amplify a couple of points that Ramanan brought up, and this is what I see as the reality in most of the African countries, at least in the region, is that the basic infrastructure, the basic things that we need are not just available. One, most of the health facilities have no running water, and that's very disturbing. And so there's we can't do stewardship. We can't depend on new molecules. We can't depend on, when we cannot prevent infections within a health facility. And this can just be a few miles out of the central, the CBD, water is an issue. We look at out of stocks, it's a chronic problems. Most of the essential quality assured antibiotics are not just available. And when we talk about the excess, because one can walk and buy any antibiotic, without a prescription, those are actually a narrow range of antibiotics. The most critical ones, they are not available in most of the health institutions. And so we end up having really prescribers depending just on, on whatever is available just to try and save the day or their patient. When we look at the supply chain issues, again, we see that, it's tilted towards the high-income countries, especially in pandemic situations. It does not favor low and middle-income countries, as has been pointed out. And these are real issues. We talk about, the fact that, in a number of these institutions, guidelines might exist, or they might not exist. The capacity building should be part and parcel of the R&D actually thinking, and also looking at, really incentivizing really R&D in low and middle income countries, but by actually trying to invest in institutions. But the other bit also that we have an issue with AMR is that we still fail to get our political leaders have a buy-in. And part of it has been the issue of semantics and the issue of communication, because we have not effectively, as public health experts, really communicated, what antimicrobial resistance really is, what the consequences are, to actually have them have a buy-in. The political will is not really there. The appetite isn't as much as where we want it to be. And so I think we still have a lot of work to do. And, my last point would just be that, in order to address the current R&D failures, or we need to understand that what has not worked. We need to look at the current incentives. Why have they not worked? And why have we lost about 6 huge pharmaceutical industries in the last 4 years? They've exited the market. What can we do about it? There's a reason that they don't want to invest in antibiotics. And so, let's try and look at some of these mechanisms. There've been, the talks around, the push mechanisms, delinkage models that actually delink the sales volumes and the profits, so that, unless we start addressing this in a very proactive way and in a manner in which there's some global consensus of some sort, I don't think that, low and middle income countries are going to be left behind, and we will not see any progress. We are only as strong as the weakest link. Thank you.
Yes, thank you very much. That's very difficult. I mean, you say 4 have disappeared. I mean, that's what, I mean, can't we use some of that global fund to incentivize pharmaceutical industries in some way to produce antibiotics? Or not produce them? They've got them on their panels, but they just don't process it through. Anybody who knows about the global fund? Okay, well, let's just go on to a question. We've got Benito Atienza from the Philippines. Benito, would you like to ask a question? Thank you. Floor's yours now. You're unmuted. Benito, we can't hear you. Benito, I think we'll come back to you, and I might take the next speaker who wants to come in with a question. Kayleen Mata, who we heard from yesterday as well. Kayleen, would you like to ask your question?
Yeah, thank you very much, and hello everyone. It's so nice to see friends and colleagues here. So maybe I'll switch directions a little bit to national action plans. What do you think is needed in order to fully fund and enroll national action plans into action? In the other, maybe one small follow-up to that is, we do have very likely some physician leaders in the audience. How can they help support national action plans as well? Thank you.
Thank you, Kayleen. Who'd like to talk about?
Maybe let me start.
Yeah, go on, Mervyn. Have a crack at it. Have a crack at it.
Let me take a crack at it. Yeah. I think this is very, very important, and it's really dear to my heart. Yeah. So, there are a number of reasons, but I'll try to narrow them very, in a very brief way. Number one is that we, I spoke about the momentum earlier on, that there was that momentum. Global action plan has been passed. Let's get it going. And so that momentum was actually, and so really countries develop their plans. But there was a critical mass of countries that did not have actually funds to even develop a national action plan. And so what did we do as a global community? We put some funds together through WHO and the tripartite, and gave some countries and supported them. So it's not, and these countries told us they had no money to develop their plans, and now all of a sudden we expect them to have money to actually put into implementation. That was, that was one fundamental issue. Number two is that there's not been the political will that resonates, that actually translates into implementation, especially funding at the national government level. That does not occur. Number three, most plans, they may look good, and when you look at the governance actually structure, they may have a secretariat, they've got a national focal person for AMR who's supposed to actually do so many activities. In almost all the countries in the region, there is not one full-time person that focuses on AMR. They've got their primary job is as a lab scientist, as a pharmacist, as a medical doctor, and then they've got 5% to now try and organize, this huge national action plan. So, it's, unless we, we start putting, money really where our mouths are, it's very difficult to actually move at all. And then, there are the disparities of, lack of data in some countries, and, lack of, human capacity and resources to be able to implement. And then, of course, the other things that we've talked about in terms of access and other issues come in. So, just to stimulate the conversation, that's where I would start from. Thank you.
Thank you for that. I think Heidi was putting her hand up.
Yes.
A non-virtual hand.
Non-virtual hand. Well, the WMA have stressed that their national members raise several issues in their countries. And depending on what the needs are, of course, there are rich countries that have more resources, and there are countries that have less resources and have other needs as well. But in every country, there are things that can be stressed. So the WMA have stressed that, of course, an equal access to healthcare and strengthening the basic health of the whole population is of importance, because then we'll be more resilient to infections as a good basis. And another thing is to develop more diagnostic tools and also health technology. It's not about the antibiotics, but good diagnostic tools, the aggregated use of data so we can track infections, so we can target infections and have a better control on the spread. That is extremely important, and that can be made in any country. And we have seen a number of techniques being developed over this last 2 years. And also to secure access to healthcare and like the universal health coverage, to work so that everyone should have the basic needs covered, and the development of primary care. As an example, both the WMA and the WHO has stressed the importance of this. So yes, there are a number of things that we can and should address in each country. Thank you.
I mean, the question, sorry, Sabia, thank you.
Sorry, just a quick input in terms of implementation of national action plans and the need for financial resources. I think there's an equal need for technical capacity development, because we are all aware that there are lots of really good evidence-based interventions that have been proven in different country contexts, but it's taking these proven evidences or interventions and then adapting them and adopting them in different country contexts that has a different external or organizational culture. And as much as we need funding, we also need to have the ability to adapt, adopt, and run interventions and monitor the impact of them in that way. So I want to motivate equally for human capital development in implementation research, or implementation science, or operational science, to make sure that what is already proven elsewhere can have equal impact in other countries. Over.
Thank you. I mean, what you didn't mention is education. If one can actually get some education locally, and then, I mean, going back to Ramanand's point, it's it's the nudge factor. If you can then get that going on the ground level, then possibly one can succeed in certain things. No, interesting question and very interesting answers as well. I see somebody's put something in the question and answers. Would you mind raising your hand and asking your question, rather than, even if it's a comment, rather than looking at that Q&A bit, because we're not looking at that. So there's a question from Nigel Duncan, who is a WMO PR associate, I think. Nigel. We can't quite hear you. Sorry. Magda, are we having problems? Yeah, sorry, still can't hear you. I don't know how long to wait these situations. Okay, Nigel, while you're writing yours in, can I just pose another question to the panel? I don't want to waste time because we've only got another 25 minutes. So the next question is, some believe that the current pandemic has set back progress made to address AMR. I think some of this we've discussed already. What are your thoughts on that? And do you see any positive effects of the pandemic on the AMR crisis? So who was talking about it earlier?
Yeah, I think we spoke about it in the context of...
I don't know whether you just want to summarize that while I just get this question on the chat.
I think I would summarize this as, I think certainly, at least from my perspective, the acceptability of adult vaccination and our ability to develop vaccines quickly is a huge win and should translate into AMR. I think potentially the infection control could translate, but I'm not sure if it has happened yet. So the jury is still out on whether that will actually happen. I think there's a recognition of zoonoses and One Health as being important thanks to COVID, and hopefully that will continue to translate into our approach to AMR. And there are many things we've done for surveillance for COVID, which could potentially inform and be expanded upon in how we tackle AMR. Now, the one thing which I think Jan actually spoke about a lot more is really in terms of international cooperation. And there it's been a bit of a mixed bag. I think the world has cooperated on some things, but much more on science than it has really on things like sharing of vaccines and so forth. So here, I think what we should look at COVID as is an experience in some things that should be replicated, but also some things that should not be replicated.
Jan?
I think what we also have seen is that policymakers outside of health have fully understood the impact of a health crisis on the total of society, welfare, and of course education, but also the economy, and we've seen that in all countries. And I think the ministries of finance, and I've definitely seen that with my engagement with ministries of finance in different countries, they are now fully on board on the understanding that many of us tried to communicate for many years, that health threats has macroeconomic sort of impact if not kept in balance. So that is an opportunity actually to really use the broader understanding of both ministers of finance and heads of governments, heads of states, understanding of health crisis being something that they need to prioritize more. My concern, though, is that they see that very too narrowly, in the sense that they will only sort of invest in protecting against sort of epidemics that or that can turn into pandemics and be a threat in each of their own localities. And that is not a sustainable approach, because I think the only approach to having sustained capacity, and Sabia just talked about technical capacity, so human resources, and all of that, of course, is to have a well-functioning health system that is actually working every day on making sure that we can deliver healthcare to individuals, and making sure that we can control not the future epidemics, but actually can control the everyday infectious disease challenges. So it's not an either or. So my hope is that at least we can add substantial resources to health investments, not only from a health argument side, but also from a macroeconomic argument side. And then, of course, we need to use those resources well and actually make sure that treating and handling current threats go hand in hand with preparing for emerging ones.
Mervyn?
Thank you. Yeah. Just to add on, I think one of the opportunities that it has created is that, I mean, COVID-19 pandemic has created awareness on the impact of infectious diseases across board on the economy, and it has affected every sector, really agriculture, education, and really every sector. And I think that is quite critical. But also we have, at least, I mean, there are a few studies that have shown that, behavioral changes like hand washing have paid off in terms of reducing antibiotic use or having actually diarrheal diseases. And that is actually, good. But it also showed that, we really, as a global community or mostly high-income countries, were able to actually accelerate in record speed in terms of coming up with actually vaccines. And that also shows that, things we consider actually impossible can be done. And the issue around behavioral, though, actually, is one area where, we still, I think, may struggle now and post-COVID, because, I mean, we saw that, for example, in the African region, when we had the outbreak of Ebola, actually hand washing and all that was being done. Immediately after Ebola was declared, those countries actually became Ebola free. Behaviors went back to, to the way it is. And so really sustaining these behaviors is a bit of a greater challenge that we have, and so I think there are still other opportunities that we can leverage on. And lastly, we did see for the first time, things we thought that the government line ministries and other organizations could not coordinate on at a country level. We saw that, actually they've been able to do that. I mean, you could not go into a shop without washing your hands, or at least having a mask on, into any airport. And, these are completely different sectors, but for once, they actually came together and were able to implement these preventive, mechanisms and strategies. And so, it is possible, even when we struggle with One Health, it's still possible we can work together, because actually COVID has shown us that, any sectors, they can come together on a common issue and be able to succeed, or at least do something. Thank you.
Okay, there's a question from Katie Matter again. When discussing innovation in AMR, and with all the fragmented initiatives currently, how do you think priority setting should be handled? And is there, an existing structure that can fulfill this role? She goes on, global health security and the protection from epidemics and pandemics appeals to the political discourse in many parts of the world. So it's really about priority setting and how should this be handled? And is there an existing structure to fulfill this role? So priority setting. We all wish. Jon Arne.
No, I guess there are existing structures. Of course, WHO has a normative role in setting priorities. They of course don't have money, so they don't fund research, and therefore could also take a more distant role when it comes to at least identifying the most needed products. They can develop targeted, target product profiles. So in a way, and they could of course have clear lists of where the needs are the biggest. So I think they are fulfilling that role. Then we have the global R&D hub on AMR in Berlin, which definitely can play a coordinating role and also making sure that we have some joint priorities. And then at least within Europe, but it's also actually now a collaboration outside of Europe. It's the JPA AMR, so the Joint program initiatives on antimicrobial resistance, which will probably transform into a larger partnership now when the Horizon 2020 has gone into the next phase of the Horizon Europe Commission research funding program. So I think that there are definitely opportunities for priority setting.
I think Keelan's coming back saying, indeed, we contributed to the AMR R&D hub in the WMA by chairing expert advisory groups. So obviously they're in the thing. Dr. Emil Jamaluddin has asked for another question. Dr. Jamaluddin, why don't you ask your question, but can you make it short? Because last time you asked us a couple. Can somebody let him in?
Yeah.
That's the Bangladesh BD, if you can.
Okay. Yeah. Sorry. I'm sorry. So actually, I just wanted to give chances to others so that.
I know, well, they're shy of raising their hands. So
no, but I want to ask actually Dr. Hedy. Actually, Hedy, you are working in the WMA for a long time, I know, and you just mentioned that the beginning of the 90s, the WMA has raised these issues and they're working on it. But do you think that you have some other things to do in your term of presidency? Because, just only in a short, I'd say in Bangladesh, actually, we have just addressing this issue, creating some sort of evidence-based empirical treatment so that we can just give it to the physicians so that this AMR can be prevented and it can be halted or slowed. So that is actually, but in the context of we have actually 350,000 to 450,000 non-medics working in the society, in the community, which the government is not willing to stop them. That creates more actually the AMR. So actually, I think, what do you think that WMA should do more straight away to give their messages to the governments so that the government becomes more proactive in this regard? Thank you.
Thank you, Jamal. I'm not sure I fully covered your question. You asked if or what other things except COVID-19 that we will be able to work on during the coming year. Was it right?
No, I was just asking, actually, you're working for a long time. WMA is working for a long time on AMR.
Yes.
Okay. But what do you think? Do you think that you have to do more things so that it comes to reality that you can go for can reach the goal, and even you are not addressing the governments directly, so that whether you can just give it to your position, you can just inform the government.
Okay. No, I get.
So that it can distribute. Yes.
Yes, and it's true. You've heard us. You've also been in our organization for some time and have heard us addressing this topic for many years. And but yes, I do think that we have an opportunity to come further to reach our goal now. And the pandemic has shown that we need to pay more attention to the public health or the health of the population. And as a former speaker addressed now, the issue of the population's health and AMR as one of these important issues are up on the agenda on the finance department, on the Department of Justice, on the foreign departments, and it has been valued up where it should be, because the health of the population is one of the pillars in a well-working society. So it should be there, but it has not been. So now we do have a window of opportunity to make some change, but it won't last forever. According to research, the window of opportunity to change after a catastrophe is counted in months. So we have to push that fast, and we can't wait with our advocacy for strengthening the global institutions until the pandemic is over. We have to start now to promote that towards our governments and other international organizations as well.
Thank you.
Thank you.
Yeah, just to add on, I think in most of our countries, I mean, you know, the professionals and professional bodies are not active. They don't have conversations with politicians. They don't discuss the, you know, the challenges that they have in terms of their institutions. They don't engage with the public media to discuss these issues about, you know, so I think if you know, the medical societies at country level, the pharmacist organizations at country level, the nurses at country level, a lab scientists at country level can start talking about these and having discussions with the political leaders, with their politicians and their governments, we might see much more, maybe some more interest from our leaders and hold them accountable. Thank you.
Thank you very much. Right, I'm sort of handling 3 questions from different areas here at the moment. So let's just ask the one that you were sent, and I think this again you possibly answered, and that's really about antimicrobial stewardship. And it says, what are the significant challenges you've seen in your work to implementation of stewardship interventions, and how can these be addressed? So all about stewardship. Right, Sabia?
Great, thank you very much. So what we found during the COVID pandemic was the 2 things that were most expendable was antimicrobial stewardship and antimicrobial surveillance, because both of them were deprioritized as laboratory resources were redirected to testing and tracing of COVID-19. And this just didn't happen in low and middle income countries, although it was more felt in those countries. I think many of us are aware of the WHO AMR Surveillance and Quality Assessment Collaborating Centers Network that reported that of the 73 countries that participated, 2/3 reported limited ability to work on AMR. There was reduced funding for AMR, and there was reduced availability of human resources, as well as laboratory reagents and consumables. So that was the first aspect related to stewardship. The second was that stewardship really relies on access to and the availability of the right antimicrobials at the right time. And so it's really a contingent on uninterrupted supply chains. And so what happened with the lockdowns and the travel restrictions, that these were severely affecting the supply chains, especially when the pandemic was at its worst in China and India, where most of the pharmaceutical manufacturing and the API manufacturing occurs. So, you know, first it was the money to undertake, or the funding and the resources to undertake stewardship and surveillance were removed. And then there was a problem in that even if it was being done, there was sometimes unavailability of the antibiotics or the antimicrobials that were recommended for use because of interrupted supply chains. So how do we address these aspects? So the first part, in terms of the importance of surveillance and stewardship, is to draw on the imminent AMR burden estimates that predicts a much more dire situation than was projected by the O'Neill reports. So we have to really use these new estimates to make both a health and an economic case for investment in surveillance and stewardship, to quantify the burden and to inform how we should address this. We highlight the economic impact of AMR on already fractured health systems. And we also need to think about how we should emphasize the cost of inaction. So what will happen if we don't do anything about it? So it's, you know, the cost benefit issues of implementing interventions and NAP, etc., is good, but what are the costs of inaction? And then the second aspect related to uninterrupted supply chains is we really need to think about investing and building capacity together with addressing licensing and patenting in low and middle income countries. And this capacity development should range from everything from manufacturing APIs to post-marketing surveillance. And I want to commend the AMR Industry Alliance. Some of the initiatives address access by product registration, tiered pricing, compassionate use programs, donations, and they've just issued a request for proposals to improve supply chains of off-patent antimicrobials. But there's also a need for the industry to commit to socially responsible patenting and licensing agreements. And I would like to say specifically for antimicrobials and associated diagnostics in LMICs. And this is really a public health imperative to ensure that these products are going to be available to treat infections and minimize resistance. So we really need to perhaps revisit the IP as the main driver of investments in antimicrobial development. And we've already spoken about subscription models and pool procurement and advanced market commitments as possible solutions. So the capacity has to go beyond infrastructure and human capital development and GMP to also looking at things like patenting and licensing agreements. Thank you.
Thank you. Right, Mary McCarthy, a member of the Board of Science. Mary, would you like to ask your question?
Thank you, Parveen. This has been a really interesting session. I wonder, the reality of first-line physicians during the pandemic was very difficult, with very few options for the treatment of severely ill patients. What is your advice for the attendees on how to help colleagues become better stewards as the pandemic continues? Thank you.
Silence there. Okay, Sabia, go on.
I almost want to reiterate what I've just said in terms of the importance of continuing surveillance and stewardship programs. And I know that's easier said than done when we're working in crisis situations and we're treating really severely ill patients. But the importance of stewardship and diagnostic stewardship can't be overemphasized. And we really need to get our lab capacities moving back to focusing on stewardship, because the very drugs that we're going to need will depend on this good stewardship and knowing what to prescribe at the correct time. So I can't emphasize more reinstating stewardship programs and stewardship personnel in all our healthcare facilities. Over.
Okay, Jon Hanne.
And may I speak?
Okay, Heidi, you go first.
Oh, sorry, was this someone else?
Yeah. Jon Hanne was going to say something. But no. Okay, who's going first? Go on, Heidi, you go first.
Yes, please, Heidi.
Then Murphy.
Thank you. So the issue of being confronted with something that we have no cure for, it's generic in the medical profession. We have faced that many times over, and we will continue to face that. And based on that, handle the situation, comforting patients and taking care of their pain or other obstacles. So I think this is not new for us. It was just so big and it hit everywhere, and even in the Western countries where we are used to have I believe it was Ramanan who mentioned it. We are used to have cures for most things, and it was new for many of us. But as I said, we are trained also to take care of the situation when we don't have a cure, and we will do that over and over and be confident. And here it's so important that older and more experienced colleagues take care of younger colleagues and supporting them. And of course, leadership is extremely important. And not at least has it been important at that decision makers, politicians, people with influence have addressed the importance of the healthcare workers in the front line so that they can be resilient and hold out, be there and be capable to handle the situation despite that it is going on for months and months and months. So a very holistic approach, but we need that as well.
Excellent. can I just warn everybody at the panel, I'm going to, in about 3 minutes, ask each of you for one thing you want us all to take forward, okay? But we'll just speak to, have Yonane and Merfin first. Yonane? So Yonane, you are muted.
Sorry, yeah, I wanted to add to what Heidi said, that in a situation where we have a new disease and we don't have sort of established best practice, I think what you can also do is to make sure that we can learn and learn as a system, learn as a community. I would have hoped to see, knowing of course the chaotic situation in many contexts, I think instead of trying out widely without any controlled sort of approach, different antivirals, different anti-inflammatory drugs, I think what we should have done better in many contexts is to actually do larger scale trials to make sure that we can optimize treatment as well as test out repurposed drugs. And some countries have been better at doing that. I think it's fair to say that the UK, with its probably a top-down approach to the way they manage clinical trials during the pandemic, has really made sure that we all have learned that, for instance, dexamethasone is a treatment of choice for severely ill patients. And I think in some hospitals in the UK, probably more than 10, even maybe up to 15% of admitted patients were enrolled in clinical trial. I think we should have done better in most contexts and actually making sure that we learned from what can be the most optimal treatment.
It was data, isn't it? We should have put everybody in trials, clinical trials rather. Merfin?
I think we can also just add on, I think not forget that it's important to really take a health systems approach, and really strengthen the health systems, but also not forget actually primary health care, because that again is something that we seem to have let go, and and so senior physicians should be able to really invest a lot in terms of not just actually mentoring, but ensuring that our health systems are actually, they are strong, they can respond both to pandemics and epidemics whilst at the same time be able to continue with routine care, which was actually disturbed in the pandemic period, and there will be consequences for that, unfortunately.
Well, thank you very much indeed. We're coming to the end of our time, so I think, if I may sort of push you all to give us one thing you want us to take home with, a message that we can actually either do ourselves or you think is the most important of all in terms of AMR and stewardship and the future, which at the moment looks extremely dismal. So just because the way you are on my screen, Ramanan, you're first, I'm afraid.
Mine is easy. So I think there are many things we should do, but I would put my money on vaccines right now, because this is where we can make the biggest dent in the most immediate sense on AMR. And in the meantime, I think we need to solve many other of the technology and innovation challenges, but I would start with vaccines, and I would hope that just like CEPI grew out of the Ebola experience, that an AMR set of vaccines grows out of the COVID experience.
It was extraordinary, wasn't it, how quickly it all happened. And, if you're pushed at it, the science does sort of take over. Sabia?
So I want to build on the lived experience of the COVID-19 pandemic and its health, social, economic, and we've all lived through it. The whole world knows what a pandemic can do to civil liberties, to health, and to everything else. So we really need to leverage this knowledge or this awareness of the pandemic and mobilize the whole of society around the silent AMR pandemic. And I know we say silent all the time, but we really need to highlight the fact that this pandemic is going to be far worse than COVID, because it affects humans, it affects animals, it affects plants, the environment. And it really is a One Health issue that has an impact that is going to be so much more far-reaching than COVID-19. So let's build on this awareness, this knowledge, the dangers of pandemics, and get mobilization to address it, whether it's top-down from the politicians or bottom-up from civil society. Thank you.
Thank you, Sabia. Gosh. Merfund?
Thank you so much. I mean, in 1905, George Santayana said, "Those who cannot remember the past are condemned to repeat it." We have a great opportunity, and especially looking at the low and middle income countries where I spend so much of my time and work, you know, we were not ready. Even when we had opportunities, when the first wave came in, we thought that only the West was going to be affected. Our governments were not ready at all. We did not prepare to have really supplies in place. Our health systems were not ready to handle anything like this. And yet, what would be, we need to do something. We can't keep really silent. WMA is an active volcano. It's not silent. It's a very active volcano. It has erupted. And we have to do something. Let's learn from this pandemic to strengthen our health systems, to address the issues around access, issues around actually equitable access, and really strengthen our countries and our commitment as a global community. Thank you.
Thank you very much. Jan-Arne?
Yeah, thank you. I guess I spoke about the opportunities now for trying to piggyback on the governmental negotiations and discussions on what we can do after the COVID-19 pandemic sort of improvement of the international system. But instead of focusing on that, I would say as medical associations, as professional organizations in countries, I think you cannot wait for the governments to make the right decisions. I think you should liaise yourself with other professional organizations in your country to really do a One Health approach on what the professionals can do and what you can do as professionals, but also what you can challenge your own government to do. And we need that bottom-up approach in all countries. There are trade-offs in that One Health perspective. If there were no trade-offs, we wouldn't have a problem. So there are trade-offs, and I think those can be discussed and negotiated sort of softly by professionals better understanding each other. So I would encourage local partnerships among veterinarians, medical doctors, nurses, and other professionals. And thanks for the opportunity to be here.
Yeah, well said. So Heidi, it's all on you really as a president-elect, getting the world, physicians, surgeons, healthcare workers, vets all together. So what's your top ask?
So there are so many wise things already said. So mine was vaccines, since WMA is, as I opened with, stressing vaccines globally to the populations around the world, and not only the COVID-19 vaccines, but the full vaccine programs for children and also to grown-ups when they are being developed. But if I should add something new, then
Sure.
this hasn't been addressed yet, I would add to work for the universal health coverage, so that we can rise the health and improve the access to health care for the whole population globally. And as I mentioned earlier, or one of the questions earlier was the frustration when we have a situation where we have no cure, as we had now. But that is one thing. I find it much worse to have a situation where, as Murphy addressed earlier, there is a cure, but we can't access it and give it to our people. And so that's what I've addressed. If we could have a universal health coverage and good health in a population with sufficient resources to healthcare, we would have better health, and then we will be more resistant to infections as well. Thank you.
Thank you very much. Some very wise things to take home. Can I just say, it's been such a privilege for me to really corral you all, so to speak, and we've learned so much, and all of you are just wonderful speakers and terribly inspirational, and I'm sure the attendees have really taken much from your wise words, but also your challenges for all of us to do our bit. So really, this is the end of a two-day of sessions, closing the scientific session. But can I also thank the attendees? I'm sorry they felt rather challenged to raise their hands, because I know there've been lots of questions coming in saying I don't want to ask, but you know, thank you for being there. And as I said, they are going to be online, so you will be able to see all of you again. And I for one, concentrating on trying to corral you all, have not been listening entirely to what you've been saying, but obviously it's in there somewhere, which needs to be sorted out. And can I also thank the IT team, the WMA and the BMA, for really producing such a wonderful couple of days of seminars. So thank you all very much indeed. Thank you for your time. And can I really give you all a warm-hearted thank you for what you're doing and what I think we should also take on board and do ourselves. So thank you all. Goodbye, and look forward to meeting
Thank
you
you.
in real life. Bye-bye.
Bye.